plenary research talks. First one on the list is Dr. Szaflarski. Dr. Szaflarski is a medical sociologist with health disparities and health disparities researcher. Her research focuses on barriers to optimal health for vulnerable populations, including racial and ethnic minorities, low-income groups, and people living with chronic conditions. Dr. Szaflarski has conducted and published studies examining immigrant mental health, social factors in epilepsy, and the role of religion and spirituality in HIV. Her work has been funded by the NIH, state agencies, and private organizations. Dr. Szaflarski has partnered with community and advocacy groups on community-engaged research projects. It is so nice to have you here. Just give me a moment and let me spotlight. Oh, you are spotlighted. Okay. If you have any slides you want to share, or okay, I'll give you permission for that really quickly.
Thank you.
You should be able to share now.
I keep getting a message that it's disabled.
Okay, just give me 1 second then. So sorry about that.
No problem.
I think it should be working now.
Yeah.
Yes, I think so. Can you see it?
Yep.
Great. Well, good afternoon. Thank you so much for having me, and thank you for your kind introduction. I appreciate it. And I'm also so happy to see young people so much involved in global health issues and from different specialties too. So it's very encouraging to see the focus on social factors and global factors in health. We need it in every area of our life. So today I am very pleased to have an opportunity to speak with you about the social determinants of health, the framework for achieving health equity. So the objectives for my talk are to describe the social determinants of health framework, to define the concept of health disparities, and also to focus in particular on the social determinants of health and health disparities in epilepsy as one area of my research. And finally, we will identify strategies that address disparities in epilepsy and other areas of health. The social determinants of health are defined as conditions in which people are born, grow, live, work, and age. This framework for social determinants of health has been introduced by the World Health Organization, in particular the work of the Commission on the Social Determinants of Health between 2005 and 2008. Since then, much evidence has been accumulated across the globe on the role of social factors in health. So in different populations, in different countries, and globally, we know that the distribution of money, power, and resources at all social levels from the global to local makes difference for health of individuals and communities. There are inequalities in health. And these are defined in the WHO framework as the fair and avoidable differences in health. Here are some examples of the social determinants of health. Socioeconomic status, that we often refer to as SES, that encompasses income levels of individuals, educational opportunities, occupational status, and in addition, employment status and work safety are very important for health. Gender and gender identity are important. There are differences in health by race and ethnicity, by levels of access to food security, and access to housing, utility services, and so on. Early childhood experiences has especially been identified as critical for health status of individuals throughout their life course. So the early age really sets up individuals for the opportunity to have both the best optimal health or for having poor health or not optimal health throughout their life course. Other factors in health include social support and community inclusivity, how safe is the place where you live, availability of transportation, other neighborhood conditions, including physical environment in which individuals live, and access to safe drinking water and other environmental factors that may influence health. Even recreation and recreational opportunities make difference for individuals' health. So here in this slide, you can see the WHO framework for the social determinants of health. And this framework identifies two types of factors that influence health and also that really shape up health inequalities. These are structural determinants of health to the left, the two left boxes, the intermediary determinants of health in the middle, and on the right in the box, you have the health outcomes of individuals, communities, and populations, and the levels of health equity or inequality that are present. So the box on the left, far left, those are the socioeconomic and political contextual factors that shape health of individuals and groups. These include governance, macroeconomic policies, social policies, public policies in terms of education, health, and social protection, and then also cultural and societal factors. Then the next box includes social factors that exist at the individual level that shape health. Socioeconomic position, social class, gender, ethnicity, race, and other social identities that individuals carry. In the middle, we have a series of mechanisms or factors through which the structural determinants of health are believed to operate as they shape health status of individuals and groups. Some of these factors are material circumstances, behavioral and biological factors, and psychosocial factors. And the last two I'd like to mention is this idea of social support, social capital existing at the community level that exists somewhere in the middle between the structural determinants of health and intermediary determinants of health, and allow these different types of factors to interact. But in general, how cohesive a community is will determine how healthy individuals in this community are. And finally, to the right, there's the health system box, which really encompasses all facets of healthcare systems that impact individuals both at the social levels and then also in terms of their health outcomes. In the United States, health disparities are usually defined broadly as the unequal distribution of disease and mortality across different social groups based on socioeconomic status, gender, race, ethnicity, and other individual identities. In the United States, as in other countries, we have moved toward reaching the goal of eliminating health disparities. So first, in the United States, we accumulated bodies of evidence that has documented disparities by race, by socioeconomic status, and so on. More recent work has really focused on differences by other social identities, such as gender or sexual orientation, such as where we live, so place, contextual factors. And so the national goal for public health in the United States, as in many other countries, is to improve health for everyone, but that can only be done by reduction and elimination of health disparities. And how to do it is still a challenge, but we as a society have a plan and have some ideas that could work. And now I'd like to turn to one area of my research, and that is in the area of the social determinants of health in epilepsy. So epilepsy is the fourth most common neurological condition. It's a condition of the brain causing seizures. And so if someone has seizures that are unprovoked, and especially if they've already experienced at least 2 unprovoked seizures, then they are diagnosed as having epilepsy. There are 50 million people worldwide that have epilepsy, and about 3.4 million people in the United States of all ages. And it's important to note that epilepsy may happen at any point in life. So there are children who are born with seizures, but then throughout life course, anyone can actually get epilepsy or seizures at any point in life. So if we know this already, we can start thinking about social conditions, which I mentioned previously, that change throughout the life course, and that will affect the life of people with epilepsy in different age groups and across their lifespans. So the literature on the social determinants of health in epilepsy specifically is still limited, and it's kind of fragmented. There's no one great resource book where you can go to and find out which social factors shape epilepsy care and outcomes. However, there is some evidence regarding the importance of socioeconomic status, race and ethnicity, age, gender, contextual factors, and also a little bit of evidence about these mechanisms or intervening factors, such as psychosocial factors, like psychosocial resources, like social support, for example, and how they impact lives of individuals with epilepsy. In terms of socioeconomic factors, the literature shows that socioeconomic deprivation increases incidence and prevalence of epilepsy. In addition, people living with epilepsy tend to have lower education, household income, and health status than people who do not have epilepsy. Furthermore, finding employment is difficult for epilepsy, so that will shape their socioeconomic status. However, when we assess the research, sometimes we find inconsistent or mixed findings about the role of social factors in epilepsy. And one reason being in that there, as you saw in this complex model of the social determinants of health, that multiple issues need to be examined in their relationships, and that has not been done yet in the epilepsy literature. So then when you look at the literature, you may find associations and findings about these associations between different factors that are a little bit different based on what health measures are used in the studies, outcome measures, and controls also used in the studies. So for example, when you look at the prevalence of epilepsy and influence of social factors on the epidemiology, the findings may be a little bit different than when you look at adherence to anti-seizure medications or access to health resources such as health insurance or health literacy. But some of the literature is already out there. In terms of race and ethnicity, in national adult samples of people with epilepsy, no race or ethnicity or even nativity differences in visits to neurologists have been noted, and also not in the use of anti-seizure medications. So that means that different racial groups with epilepsy have about the same access to neurologists and the use of anti-seizure medications. However, there's other research that shows that African American people with epilepsy have higher rates of acute care and deaths caused by epilepsy. They also have lower rates of receiving advanced treatments for epilepsy, for example, epilepsy surgery. Also, some differences are noted for other racial groups. Native Americans especially have been shown to have some barriers to epilepsy care. And Hispanic and Latinx communities have specific cultural and social barriers to care that also may impact the care for people with epilepsy from these backgrounds. Now, age is very often looked at as a biological factor in medicine and health. However, we have to keep in mind that age is socially constructed too. The different social groups in society have different experiences because of age. So the same thing in epilepsy. Certain age groups have specific needs and vulnerability in epilepsy, including children or older adults or working age population where employment is a big issue for people with epilepsy. And then young adults, the issue of driving, receiving education, and also looking for employment. That could be difficult for persons with epilepsy. Again, how individuals are posed throughout their lifetime to be able to cope with epilepsy throughout the life course is very often set at an early stage. So if child is born in a background where parents are able to get appropriate care for the child to assure that the seizures are treated, that the child receives education and grows up in a advantaged environment, then you can expect the outcomes later in life in epilepsy be better than if all these things were not available early on. Now let's think about gender. No gender differences have been noted in the experience of living with epilepsy among children. However, some gender differences have been noted among adults with epilepsy. For example, women have been shown to have higher use of neurology versus general practitioner services. And that's important, especially for people with treatment-resistant epilepsies, for whom more advanced treatments and more advanced care is needed for them to have the best optimal outcomes. Quality of life in epilepsy, which is a construct we often use to describe the patient-centered experiences in health. Quality of life is a construct that encompasses people's perceptions on life with the disease and their social and psychological well-being. So women especially may have lower quality of life because of the issue of childbearing, and epilepsy very often preventing the childbearing or having special types of circumstances that are needed. Epilepsy treatments can have impact on pregnancy, so then women have to be in special care, to receive special care and special treatment during pregnancy, pre and during pregnancy. So that may affect their quality of life. There are some studies of children that are showing that there are no gender differences in the rate of surgery, epilepsy surgery, and also in quality of life among younger ages. Here's some research that has pointed to the role of contextual social factors in epilepsy. In terms of neighborhood conditions, research has reported that people with epilepsy assess their neighborhood as less safe than those with epilepsy. And this may point to maybe experiences of stigma or discrimination in their communities that exist and that impacts quality of life of persons with epilepsy. There are also some studies that show urban-rural differences in epilepsy care, such as that the care is typically better in urban areas than in rural areas, but we don't have enough research to conclude that that's in fact the case. In terms of macrostructural social conditions, all these things listed here, like health policies and healthcare budgets, are important for epilepsy. And one of the things on the list here is also treatment regulation. So regulatory issues in epilepsy treatment, availability of treatment, and so on. Epilepsy treatment is keeps evolving. There's so many more treatments available today than in the past, but that has to go through the regulation, as we know, through the FDA and at the national level. So how fast that process moves, and research and development in general in a society, that will make a difference for outcomes in epilepsy. Generally, there are some studies that show very high economic burden of epilepsy in the US. So the better we address, treat the disease, the less economic impact it will have on society. And finally, in terms of these cultural factors, as I mentioned before, what is very important in epilepsy is to increase public awareness and knowledge of epilepsy, and especially for the purpose of reducing stigma and discrimination that will allow people to have, with epilepsy, to have more fulfilling lives in our society. There's very little research that points to specific mechanisms through which the structural social determinants of health operate to shape epilepsy epidemiology, outcomes for individuals, and also epilepsy care. From that model I presented previously, you can see how complex these associations are, and so big studies that undertake examination of these different factors are not really, have not really happened. So there's limited and fragmented systemic evidence regarding these mechanisms. But what we know, based on the larger social determinants of health framework, is that these things listed here, material conditions, behavioral factors, psychosocial factors, and health system factors, make a difference for how many individuals with epilepsy we have in our society, what kind of access to care they have, and then based on their access to treatment, receiving treatment, and their outcomes will be measured. So based on the larger WHO social determinants of health framework, I proposed this more specific framework for looking at social factors in epilepsy specifically. And so I'm going to start with the box on the right, which looks at epilepsy epidemiology, epilepsy patient outcomes, and epilepsy disparities, which all are shaped by all these other factors in the model, starting with the socioeconomic and political context of epilepsy, such as public policies and culture. Then more in the middle, we have socioeconomic status of individuals, social class, gender, race, and so on. And these intermediary factors, such as behaviors and psychosocial factors and epilepsy care, that make difference for these outcomes that we're interested in research and interventions: epidemiology of epilepsy, epilepsy care, and epilepsy disparities, how we measure them. So me and my colleagues, we have conducted a series of studies looking at some of these issues. Again, looking at the whole model is pretty much impossible in one research study or even in a series of studies. So you have to do multiple studies and then compile the evidence and see where we are. One of our most recent studies have examined the role of poverty, insurance, and region where people live in the US as predictors of epilepsy treatment among adults. And our main finding in this study was that the lack of insurance and also living in any region outside of the Northeast made a difference for the ability to see a neurologist. So those people who did not have insurance and lived outside of the Northeast were less likely than those with insurance and living in the Northeast to access a neurologist in the last 12 months. On the other hand, poverty was the key barrier to the treatment, to receiving anti-seizure medication and being able to use it. And so these are just a few social factors that we examine in this particular study. What is interesting, I think, is the health system level issue of the shortage of neurologists that has to be addressed at the national level. And the fact that in many regions of the country, we don't have enough neurologists. And so then the people with epilepsy will not be able to get appropriate and timely treatment. This is especially important for, as I mentioned before, for people who are living with treatment-resistant seizures, who need more advanced care. And not having a neurologist in their state may make a difference about how quickly they will receive care. In fact, there is research that shows that some people with treatment-resistant epilepsy wait 7 to 15 years to get into subspecialty epilepsy care to be able to get advanced treatment, such as to be evaluated for an epilepsy surgery or to receive epilepsy surgery, which actually is very efficacious, shown by research that many people get released from seizures that way. So the shortage of neurologists is a system level factor, and it is a social factor, in addition to these other socioeconomic factors such as lack of insurance or poverty that make difference for health status of these individuals. In another study, we actually focused specifically on persons with treatment-resistant epilepsy. And we examined the social factors that would impact health status that was measured by self-reported health, either by patients or by caregivers, and health-related quality of life, as well as mood states, so psychological outcomes in this patient population. As you will see on the left, there's some statistics about the financial and income status of these individuals. So 23% of patients in this sample had low income levels, less than 40,000 a year family income. Some of these patients reported financial strain in terms of money situation. In fact, 11% reported having to cut back, and 6% reported that they could not make ends meet. A smaller number, but also about 12% of individuals reported food scarcity, experiencing food shortage either sometimes or often. And the same thing in terms of not being able to afford medications for epilepsy. Maybe not those who often couldn't afford. We didn't have those patients in our sample, but sometimes some of these individuals reported having issue with getting their medications for epilepsy. Our main finding in this study is shown here in the chart, where we looked at the association between age and income and health ratings of the patients, either provided by the patients or by caregivers. And so what you see in this chart is that individuals with lower incomes are on the left bars, and then individuals with higher incomes are the bars on the right. So what you see, the bars on the right, at the higher income levels, we generally see higher health ratings among these patients. However, there is interaction with age. So the gray bar represents younger ages, and the dark bar represents, the black bar represents older ages. So what you see is that in younger ages, you always have higher health ratings, regardless of income, right? With older ages, you have lower health ratings. Although, as we can see, at higher income levels, the health ratings are higher. So there is definitely a relationship, and we know it from many, many studies that socioeconomic status shapes self-reported health of individuals and other health measures. So already knowing about many social barriers to care in epilepsy and to achieving optimal outcomes among people with epilepsy, the Institute of Medicine released a report in 2012 by a panel of experts titled Epilepsy Across the Spectrum, where specific strategies were laid out to address epilepsy care and also elimination and reduction of health disparities in epilepsy. And here are some things that were recommended in that report. The surveillance of epilepsy, including health disparities, service use and cost, quality and access to care, risk factors, and patient-centered outcomes. Also, public health and prevention, new strategies or strengthening of strategies in terms of health policy and public health systems were recommended. In terms of care specifically, there were calls for improvement in quality, access, and value of care, especially in terms of improving access to and quality of epilepsy care. Health professional education was another point listed as an important issue to address, addressing culture and education of trainees, medical and health professional trainees, and then continuing professional education in terms of epilepsy was important. There was also a role that was kind of designated for epilepsy organizations and epilepsy centers. So these specialized organizations that are advocates for patients and families have done so much in the United States, especially the Epilepsy Foundation at the national level and at the local levels too, have worked and done numerous interventions and programs for families, and also working with the professional groups to strengthen epilepsy care. Improving community resources and quality of life at the community level also was seen as important, and education of patients and families, and generally to strengthen the public education and awareness campaigns nationally. So many of you are probably aware of the national health plan that we have in place, which is called Healthy People. So here's an interesting item on epilepsy from that national plan. In 2020, one of the objectives in that national plan was to increase the proportion of people with epilepsy who have uncontrolled seizures who would receive appropriate medical care. So see a neurologist or epilepsy specialist at least once in 12 months. And as you can see, between 2010 and 2020, there was 10% improvement in that goal at the national level, which shows you that 64% of people with treatment-resistant epilepsy have been able to access a neurologist in the last 12 months. However, look how big of a gap there still is to get to the 100%, right? So we continue working on this objective as we go forward. It is really important to look at the different groups within our society that can really contribute to strengthening epilepsy care and outcomes for people with epilepsy. So patients and families can become better advocates for themselves, to get educated about seizures and how to best access care. But there are also these advocacy groups, like I mentioned, the Epilepsy Foundation, also C.A.R.E. Epilepsy is another national group organization that speaks for these patients. They're health policy makers that actually make it their work in state legislatures and at the national level to help to improve epilepsy care and also reduce stigma and discrimination for people with epilepsy. The healthcare system administrators are also important. They understand what is needed in terms of care for epilepsy. And there's also a specific role for academic institutions to engage with education, research practice, and community and public activities on the issue of epilepsy. So winding down, I would like to just make a few final points to summarize what I talked about. So the social determinants of health are responsible for most variation in health status across populations and specific social groups. They are responsible for production of inequalities in health. The WHO framework on the social determinants of health guides us in efforts to understand what social factors in health are and how they impact health and healthcare, and how to develop and prioritize interventions to eliminate disparities. The social determinants of health framework can also be applied to understand epilepsy and epilepsy care disparities in order to develop interventions at various social levels. And finally, as I mentioned just a minute ago, the stakeholders on epilepsy are multiple and they should work together. And we still don't know to what extent we have utilized the collaboration between the different stakeholders to improve outcomes for people with epilepsy. So thank you very much, and I'll be happy to answer questions.
All right, thank you very much, Dr. Szaflarski, for the talk.